of all the stuff that we were just talking about, the medical care, the home birth, all the stuff, what is our biggest thing of what we don't know? We don't know anything.
Yeah.
We're having babies and we don't know. We don't understand going into the hospital and why they induce us. We don't understand why they give us meds. We don't understand why they give us an IV. We don't understand. No one's explaining anything. The doctor's not explaining the whole time why you're pregnant. You don't get to explain while you're in labor. You don't understand what's happening after you give birth. You really don't know anything going on. So then when things happen to you, you're like, oh, they gave me an IV. There's something wrong with me. You know, like you start taking things that might have been so small. Yeah.
I dilated 1 centimeter with my water broken in the last 14 hours and they forced me on Pitocin. Why would they do that?
Why would they do that? Why, when everybody's saying all this stuff, all these people that don't understand the body, that don't understand how medical stuff works, that don't understand what's going on in the hospital, they're telling you their opinions or their thoughts of who knows where it comes from, you know? And so we end up in this thing where people are like, I got abused in the system. I got abused at the hospital. They didn't, all these different things going on. But then there is
somewhat true.
Which
you were not given a full spectrum of information.
You're not informed.
Informed consent is severely lacking. True informed consent.
Yes, we really need more information. And I think it starts from providers.
The pendulum swings in both directions.
Right. And you have to ask. Yes. You can't just assume you have to have that conversation. And I think that it's a good point to what you guys were talking about when I came on is meeting in the middle. It's you have the conversation and say, hey, these are my fears, but then actually having a provider who's willing to have more than a 5-minute conversation with you about your fears and what your options are.
Hospitals should start having pregnancy support group meetings. We can't expect doctors are becoming fewer and far between. Nurses especially are becoming fewer and more far of them between. So we need something where we can't expect every nurse and every doctor to stop and explain to you for the next 45 minutes what the hell is going on and why you should at least get the port for the IV. But you should be able to go into the hospital with a clear expectation of why you're going to be asked to do certain things and a clear reasoning for why you will or will not do those things. And the only way that is really going to happen is if we start getting the support staff in the hospital and more interactions between patients and the hospitals before they go into labor. And hospitals always do those birth classes, but it's my birth class was super full of woo, and it was taught by a doula RN at my hospital. And she taught us about breathing techniques and positions. And it's now that I've gone through natural labor, very long labor, I realized that it didn't friggin' matter. It mattered not at all what I knew about positions.
No, your body is either going to do it or it's not.
I just did whatever I wanted to do in the moment. And I wasn't sitting there being okay, I should be on my hands and knees because it'll help my baby rotate a little bit. I was on my hands and knees because sitting down hurt.
Right. And it feels like something's at your butt.
Yeah, it really does. So the birth classes in the hospital should be more about let's build your birth plan together. I think that's so smart. The process. When you get to the hospital, you're going to go to triage. In triage, they're going to check you for these things. This is why they check you for these things. Then they're going to expect you to get an IV. Here's why we would like you to get the port put in. And here's the parts of it that were totally fine. If you deny doing the port, we're going to try to convince you into it. But if you agree to the port, but don't want the IV fluids right away, we're totally fine with that, because when you need the IV, if you need the IV, it's already there. This is what's going to happen. We expect your labor to go like this. If it doesn't go like this, these are the markers we're going to be looking for to start augmenting it. If you're dilating super slow, very, very slow, but you're doing fine. You're up, you're walking, you're talking, your heart rate is good. Your baby's heart rate is good. You're drinking enough fluids. We're not going to push you on Pitocin. But if this happens, we'll try to encourage you to do Pitocin. I really think that just having advocates,
like a trained set, like
Yes.
that might be a good
Trained
idea.
medical.
Instead of having like all the doctors, all the nurses, have like a specialized group of people who may include a physician, maybe a nurse.
and do it before labor begins, because as we all know,
that is the one thing that people say that drives me up the wall is they're like, we'll talk about it when I'm in labor. And it's like, no, that's a terrible idea. You need to talk about this when you have all your brain cells.
I had no idea. I had no idea what the hospital was looking for when they decided to put me on Pitocin when I was in labor with my daughter. I had no idea what they were watching for. I had no idea what anything was. It wasn't until I reached 24 hours after my water broke that anybody explained to me, at 24 hours, we want you to have a C-section. Like, if I had known that, if I had an idea of what labor and like the management of labor and delivery, like I said earlier, we know ourselves, but the hospitals know labor. We need to bring the two things together long before labor begins so that people go into labor knowing.
I think we don't understand as women. Women don't want to be on no time limit, but we're on a time limit. The placenta's on a time limit. Once the water broke, you're on a time limit. Baby coming out is a time limit. It is a time limit. If babies come out premature and they can live and be in the NICU, when you're around 40 weeks, anything that happens, stillborn, easy. There's nothing you can do. Unfortunately, that is something that I learned. We're like super prepped for like preemies, but when it comes to like those other things, and I think it's a combined thing. Did you notice this? This is a combined effort. This is a combined, like, oh, you're 40 weeks. Like, I think they don't, and I don't want to say there's not enough stuff to focus on those, like, well, you're full term, your baby's going to come out healthy. Maybe that's like the assumed position of like, hey, you're 40 weeks, everything's fine. But now we've learned, no, 40 weeks isn't good. Let's go back to 39. So it's like, we're starting to learn of like, maybe this isn't such a good idea to just assume everyone is the same and assume every baby's the same and placenta is the same. Let's go earlier in prevention, because we've learned when we reach a certain point, there is no help. No matter what equipment we have, no matter what we know, once we've gone beyond it, we all know our babies aren't here. That's what happens when you go beyond it. And all of our babies were full term.
Yep.
Exactly. So there's something that I think we need to understand. Women say, I don't time limits and I want to run around. I want to do this, but the time limits are there for a reason. And the bad thing is the hospitals all are a little bit different. I do think an advocate of somebody that is medically trained to explain why we get an IV, why we induce you, why we have a time limit. It's not anything about your body. It's not anything about your baby. We want to have you guys have the best outcome possible. And hopefully in that, it's a great experience too. But maybe we're going to chop the great experience away because you're both alive and you're both here. And that's all we care about.
That's the great experience.
Yeah.
That's the great experience.
And exactly. And there's our job. You're alive. You can go home. Woo! You can raise your baby. That's what I think is where we have this, like, doctors are cold or hospitals are cold. It's like they go in and they're like
really busy.
They're like, we're a machine.
It's like, think about it. Yeah. I'm a restaurant server. On a busy Friday night, I don't have the time to sit there and like
hang out.
Yeah, sometimes when I go to take an order and I'm like, you get 2 sides with that. What would you like? And they're like, oh, what are your sides? I'll literally flip the menu over and I'll be like, sides are listed there. I'll be back in a minute. Because I literally do not have the time to sit there and
you're in the weeds.
Right. Yep.
Exactly.
Ways in the weeds, especially in labor and delivery. I don't know anybody who's gone to the hospital to have a baby and it's been like, oh, we were the only people there.
Yeah, nobody. And unfortunately, there's where the hospital fall thing is. If you know from having different babies, different doctors, different hospitals, the doctor is king. When the doctor comes in the room, they decide what's going on. The nurse staff has their things that they follow in a line, and the hospital has their rules that they follow, and the doctor follows them too. But the doctor is the one that says, oh, C-section. Oh, we got to cut here. Oh, we got to do whatever. The doctor makes the decisions. So you initially need to be sitting down with your doctor. And if your doctor's in a practice and you might not end up with your doctor needs to have it wrote down of what you guys have discussed and have it wrote down of like, yes, of like, hey, they're cool with, we reached this point. This is what's going to happen. This is what we decided. They only want to birth for this many hours and they want a C-section, elect C-section. It needs to be already done, ready, because the other doctor is going to look over real quick, say, okay, I know what's going on. If there's any situations where your doctor can't be there, which it does happen, but there's conversations aren't happening. And I feel like this is where we fall of advocating for ourselves, is a lot of us are not having the conversations. You don't have to have it before you get pregnant, because not always do we plan getting pregnant. You know, a lot of us do, but not everybody does. But when you're pregnant, somewhere along, even if it's right at the beginning, like, yay, I'm pregnant. Now what? Now what's happening? What's going on?
Yeah, one of the things that drives me up the wall is people will report that they have some questions and they have some preferences about their birth, and they'll show up, you know, for maybe a 20-week appointment, and they'll say, I'd like to talk about my birth, and the doctor's like, oh, we'll talk about it later. It's like, I always go by the rule of threes. People need to hear things 3 times before it really sinks in, which is why people get mad when their doctor asks them about something like contraception more than once. It's like, they're doing this to make sure. So it's like, if you want to have the discussion with your doctor, and they're like, well, it's only 200 weeks. What can we say about birth right now? It's like, oh, I don't know. I think we can say a lot about birth right now. You know?
So my OB with Kinsley, my daughter after Carson, I mean, we did IVF, so we knew we were going to have the baby. And so I think it was my first OB appointment with her. She's like, so what do we want this to look like? What's important to you? Like at our first consult, it was just like, we knew it was going to be a C-section, since the vaginal is what, where the issues arose from. We knew what was important, and she charted that so many times. Like, we discussed it almost at every appointment, just so it was in there so much. And I wish everybody could have that level of care. But also, to that point, I knew I had to advocate for myself. So I found someone who I knew would be on my side. And I knew to be like, we need this documented. I will not settle for less. And I don't feel like most birthing persons come in with that attitude, especially with their first kid. You don't think you need to advocate because you're like, well, that's what that's what the providers are going to do. That's what my midwife is going to do. That's what my chosen person is going to do. But unfortunately, we have to.
When I was in labor with John, I honestly thought that my midwives would be the ones making way more conservative decisions, because I was like, I have this ridiculously high pain tolerance and I'm so motivated to have this baby vaginally. I want to avoid having another C-section. And I really, truly put my faith in them as the people who were watching over my labor to make the decisions and help me make the decisions that would keep us the safest. And I really learned a lot about advocating for myself that day, and being able to look at a medical provider and be like, no.
Yeah. Which is a full sentence. No.
Yes. And because I had asked repeatedly over and over, and I know Danielle, you know the saga. You ask over and over and over, are we okay? Is everything okay? Something feels wrong. Is everything okay? And they're just like, you're just in pain. Everything's fine. You're just in pain. And you think, because they're the ones looking at the data, they're the ones looking at the heart rates, they're the ones
the fetal tracing,
everything like that. You think that they're going to advocate for you because they have the experience and the knowledge and the know-how. But you do learn a lot about, you need to make sure that your desired outcome is what happens. And I thought my desired outcome was a vaginal birth. And I realized that that was their desired outcome. My desired outcome was my family complete, was to have my child.